Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 186. It's the last session of the year, and it's been a pleasure bringing this symposium to you throughout the year. A Merry Christmas and a Happy New Year to you. Just a small brief announcement for me before I take you over to the cath lab. It is to continue your efforts with the CME. It's available to you. We've made a further enhancement. Now the window has been extended. You have 24 hours to claim your CME credit. We'll also try to make it for the archived cases, and I hope this will be extremely useful for you. With this introduction, and for our last case of the year, let me take you to the Cardiac Cath lab where Dr. Sharma and Dr. Kinney are standing by. Anu, right. Good morning. Samin, good morning.
Good morning from the cath lab and cath lab staff. For it's a good. Everybody can be seen. Nice panoramic view of the cath lab. A lot of our usual features, and we have two fellows, Jason Kaplan and Krishna. We actually total 8 fellows, but should be 9. They already have made it very clear. With our program, we need 9 interventional fellows. But they have the speaker. Can you have listening things, right? Yeah, good, yeah. So yes, it has been a tremendous journey. And anywhere you go, what we have provided with this CCC Live is tremendous in all aspects. Now, of course, our coronary. Since 2009, then we added an endovascular 2012. Then we made a structural, which has become now every month rather than every other month since 2016. And soon we are going to start the imaging / microvascular testing. So there is a lot of demand for it. So we want to have 1 hour teaching every week. Will that note, once again, I would say the entire year, thank you to our listeners, our CCC Live audience, which has grown to 25,000 numbers per month. And we are thankful, and they keep giving us some feedback, and we keep changing our data. Case selection according to the requirement. Now, second, to make it more online participation, we have added the CCC, our CME seminar, that you can get a CME credit, but whether it's that successful or not, we need to see. But we'll give it full 6+ months, and then we'll go to the archives for the CME. So with that note, thanks again to all our viewers and listeners, and let's go to our case presentation of, this is our target audience for the CME point of view. Learning objectives as usual, basically the appropriate case selection and stepwise approach, and apply the principle and lesson from the recent and relevant trial. Accreditation is a 1.5 AMA 1 credit for those who will join and log in to the activity. Faculty disclosure is unchanged. Basically all of us the same. There is no new change. The commercial support, these are our support people. And then, of course, the privacy policy of the CME, all we are going to follow. With that note, our CCC Live case number 186. This is an 80-year-old male presented with new onset CCS Class I angina, had a negative stress test, but CTA revealed high calcium score and 3-vessel CAD with positive CT FFR in the LAD and RCA. EF has been 62 and basically controlled in terms of diabetes, hypertension, hyperlipidemia, and rest of the things are shown there. And then aspirin, metoprolol, medical therapy. This patient had a cath on 12/10, which revealed calcific 2-vessel CAD, 80% proximal LAD and 80% calcific nodule of the Shepherd Crook RCA, which is the in question today. Syntax score was 21, and patient that time had a Rota DES of the proximal LAD and did well with added clopidogrel. Let me show you this angiogram. Look at the calcium in the LAD with the, again, nice nodule in the proximal. The distal area also about 60% that was left alone. Not done anything to this vessel, and you here 1.75 bar, and you can see they are followed by 4/15 NC emerge, high pressure dilatation, and then stenting, sky point 4028 at 16 atmosphere, post dilated with same emerge at 24 atmosphere, and we left it there. There still was a little bit of dent because this was only the rota alone. So we did not use the IVL. I think we're learning more and more now that many of these nodule, you need not only one strategy, even this was a 1.75 bar. You need to combine with the IVL to take away that dent which we left there. So maybe we'll learn from it in this case of the right coronary, which Anu is going to show that where we are now in terms of your right.
Samin, quick question for you.
Imaging done.
We did IVUS.
Yeah.
We did IVUS.
IVUS.
but I'm
But there was on the
not
IVUS was we didn't see that it was CSA. I mean the MSA was very good.
Okay.
Final. Yeah.
Samin,
today,
had you considered IVL as an adjunct there in that case for the LAD?
No, there was IVUS done and IVUS did not show. The rotational atherectomy did a very good plaque modification. Yeah.
That is probably because you went with the 175.
Yeah. Yeah.
And this is where we are today with the same LAD. EF is good.
You need to
And the right coronary artery.
replicate your success for the RCA. Copy and paste. Same game plan.
So this is a shepherd's crook RCA, heavily calcified, and you can see the significant disease is mostly in the mid, and there is moderate disease in the distal.
So the guiding catheter is sitting well there. I was surprised you didn't use the amplats.
Yeah. Well, we were thinking even to use the shepherd crook, but apparently they could not engage. But this, we'll see. Now,
No, this is a mark guide, as you know. We have our favorite guide is always mark, softer guide, and we were able to engage better. It was not that easy. Very tortuous. This is he has 45 centimeter sheath. We were thinking, should we change to 90? Usually 45 centimeter sheath reaches the thoracic aorta. In his case, we barely are still in the abdominal aorta there. So if you see that, yeah, we probably needed a 90 in this person. But we'll see. Engaged better.
6 French or 7 French?
6 French.
Okay.
Yeah. We have the 6 French here.
And the intent here with this tortuosity, would it be a 1.5 burr or a 1.75?
Yeah,
Has to be 1.5.
Yeah.
Okay.
You had a 1.5 ready or
Not even think 1.75.
So because it will be a tough one. No, question was, it's the extra support wire or regular wire you use?
No, regular. I think
yeah.
extra support wire will give you a lot of wire bias.
Okay.
So we have now the same thing me and Kiski was discussing. If we go from distal RCA from the crux all to the proximal RCA, it's not going to cover. And I don't think we should do 2 OCT run. Let us do 1. So Kiski, if you are okay, we will start from the acute angle. Just take care of the mid and prox. Is that okay, right?
Sounds good.
Because
Sounds
that's where the significant disease as well as what we suspect a nodule is going to be there.
Yep.
So it has been a direct wiring, the run through, and then followed by the rota floppy wire. And you see the pacemaker is there because we expect there will be some slow flow, although we said, I mean, or not necessarily slow flow, only just for heart block, that you can always counteract with atropine and aminoflin. But I think this is the kind of case. It's okay to give.
We are okay there.
Yeah. Can you check the path?
Kiski.
Yeah.
Huh?
Guide is kind of out, so
No.
you can check the clearance.
Guide need to come in.
Okay.
Yeah.
I think we will be able to get both, no?
Yep. We can try.
Can
check-
you just... What? It's not...
What do you need now?
So Philip, we do OCD.
Anu, there is a question for you. They'd like to know more about the MAC guide.
Okay. So can you change?
Mark guide are the Boston Scientific soft guides.
Yeah.
The good lumen 6 French is 0.070.
So
Good, right?
Okay. 1
Why
second.
you don't see a pressure?
Okay. Can I enable?
Yes.
Okay. 1 second. Enabling. 1 second. Calibrating.
What beautiful pictures.
Yeah. We got image.
Okay.
You can take it out.
All right, Kiski time.
Yep.
Yeah.
1 second. calibrating.
Flush it and keep it.
I think we can get 1.75 bar.
Yeah.
And not make that turn.
So,
Not make that turn.
so we didn't get the
I will do it,
angiocrystallization,
yeah.
but we got
No,
the
no.
image.
1.5.
Yeah.
Good.
Start of the probe, you see the 360 degree of the calcium.
Okay.
Then-
but at the show us the nodule. That's what we
Sure.
are very much
No.
interested.
Hold
So
on, hold
now
on.
we need to talk about
2
that.
o'clock.
also.
This is the
Ready?
acute marginal blanch, so more proximally.
5.
Yeah, so this is
Oh,
exactly
wow.
protruding inside.
Hold on,
Wow.
Kiski.
Mhm.
What happened? You could not do the.
Sorry, we couldn't get angiocrystallization for this probe, so maybe we can get next time. But we got a cross-sectional image.
If we can, there you go. This is a classic textbook
Nodule.
Yeah,
nodule. Look at that protruding into the.
yeah, and some part is surface is irregular, so it's a kind of eruptive calcified nodule.
Now tell us eruptive because interruption of the the lining.
Yeah, the surface is disrupted, so not smooth. It's a eruptive calcified nodule. And tandem calcified nodule. Here is also calcified nodule. And I can check the MLD. Yeah, this is less than 1.5. So yeah, definitely.
How much is it? 1.0.
1.0 is
Yeah.
MLD.
So that's what we our algorithm is. If your
Yeah.
MLD is 1, then we have 1.5 bar is good enough. That's what's going to take care of the shave the nodule. But the rest of the area, MSA is big, right?
Yes. Proximal part like 360 calcium, like 270 calcium, but this part area is like a 5.
And
So
vessel size is 4 or 5.
Large, fine.
Yeah.
So-
EEL, like AI said like a 4.0 EEL to EL, 4 vessel.
Okay, then it'll be 3.5.
This is a
Question.
3.5 15 balloon. 15.
No, Kiski.
Yep.
So the tightest area is just the mid RCA.
Yes.
Distal RCA, there's nothing. Go back to the distal RCA.
So this is a distal RCA.
Oh.
We see the 360 calcium. AI detected like a 360 orange color,
Okay.
but area is like a 3.5. It's kind of borderline in terms of the area.
Yeah,
I
we
mean-
said it was moderate distal RCA disease.
This part,
But I
sorry,
guess
this part
we-
is like a 2.7. So
Oh, real one.
Yeah.
Okay. Yeah. Can you highlight that, what your man is talking so that people understand when they're using OCT? So you see that orange line, he's saying that the arc of calcium is 90 degree. Okay, right here, 360 degree of orange
Yeah.
of calcium. And then if you see the length, it will not give us because you have to measure it separately. But more important, the CSA it's giving you, right?
Yep.
3.5, 3.1, 2.7, 2.6. Yeah.
yeah, this is a distal RCA lesion.
Yes.
So that's a good algorithm that the orange arc tells you that what is the arc of calcium, right?
Yeah.
That's a
But
good
yeah,
one.
but no. What we say is, yeah, he's telling us, but human eye also should confirm it. So we'll take
So,
this
Anu, then-
one, and the second one is why we'll show our algorithm that's published and one we presented at ESC. Kiski actually presented in ESC that how, because this is always a question that comes. Okay, you do OCT or IVUS, and then how do you select the burr? So now we have the defined algorithm that he gave you a CSA at the level of the nodule. Not the CSA, the diameter at the level of the nodule. So at the level of the nodule, can you go back?
Yeah. This is
Go
exactly,
back there. Okay. So if you see that its diameter is 1.0,
Yep.
that means we can go with the 1.5 bar. That's one. Number two, what is the calcium there? We don't see that much. Okay.
Yeah. At the level of the nodule, actually not that calcium.
Not
but
calcium, but just
before the-
behind that. Yeah.
Before the nodule part, there's like a 270 calcium.
So it's just not the nodule, it's also the calcific rim or the calcium plate around it is important for us to define what is the kind of atherectomy you need to use. So here, do we want to do RA, OA? RA is okay, that's what we like to do. Can OA be done? Yes, OA also can be done here.
Good. And I would say
Samir-
this one will combine with the IVL. I know you have, there is a question there. Yes, keep going.
The real discussion here, and Kiski may also want to comment on this, is that as opposed to just a calcified nodule, the eruptive component of it, does that correlate with any new symptoms? Is the patient having
No.
would you anticipate more unstable symptoms with this?
Now you saw that he already said. Can you give us the length of that nodule?
Length? Sure.
Yeah. So the important thing is we have only one area is the one. We needed the wire all the way down.
We'll go down.
Yeah, we're at like 8 millimeter longitudinal length of the calcified nodule, 8 millimeter.
How much?
8 millimeter longitudinal length.
Okay. Yeah, so just to say that, yes, there are data to show eruptive nodule is a little more the acute coronary syndrome. And secondly, actually, very interesting, the lumen gain with the eruptive nodule is less compared to if the non-eruptive, and a little higher restenosis. So now wire is very distal. It's a 1.5 bar ready. And let's start doing it now. Go.
So this is what I think I would say challenge we have. It's not that easy to get the burr even into the proximal RCA. We'll have to dynaglide or start burring right from the beginning. So we'll go forward. The wire.
So you can keep it tight. So we are going to go on the manual dynaglide forward. Not that way. See if we can advance manually. Yeah, a little more. So you are enough. Good. Fine. Good. That's enough. Good. So see that's why the manual dynaglide, instead of coming out, we went in. And now we are ready to do this bar. Yeah.
141.
Yeah. But went very quick. We have to go distal then also, right? Go distal too.
145. 15 seconds. 45. 20 seconds.
Good.
45. 22.
Now only we see that pulse, show the hemodynamic, yeah, they're showing it. The patient is developing the pacemaker dependence, which is not uncommon with that. And of course, with that, you always will have a little lower blood pressure because you lose the atrial kick. And Samir, what was the question?
Well, there are several questions which have come. The first, before I even ask the question, I think, Anu, this is all credit to you also. I think the best teaching point has already been established to advance on dynaglide.
Good. Yeah, good.
That to me was the real challenge which you had, and you overcame it perfectly with the use of dynaglide. There are questions more for Kiski that on OCT specifically, how do you differentiate? This is Dr. Mahmoud Al-Rais, who joins us almost every time. And his question is, how do you differentiate between a calcific nodule and a lipid plaque?
Very good.
Yeah. Calcium nodule is like a protruding mass and like protruding inside and an acoustic shadow. So even the calcium we cannot see behind the surface of the calcium nodule. And most important point is the proximal and distal part of the nodule. There is a substantial calcium sheet. That's why we can identify this is a calcified nodule. But lipid plaque is different. There's no like a calcium sheet. Just like attenuated plaque. That's a lipid plaque. So that's why we can differentiate a lipid plaque or a calcified nodule.
Yeah, well-defined shadow, echogenic, echolucent shadow will be a nodule, and basically overall if it is confluent, and that will be we put other wire, right? Yeah, put a run through again. You want to take a picture now?
Yeah, the point is nodule is protruding into the lumen. That's the point.
So Kiski here,
Yes.
this is a fascinating question for you. I cannot unfortunately make out who's asking this. The name here is Viz Boys or something. It's coming, but the fascinating question that we are detecting more and more calcium with AI.
Yep.
How reliable is that?
Yeah, very good, important question.
Well, I would say that this kind of these algorithms, AI algorithm, which they have made for the stent expansion with the calcium detection, I think they're accurate. Like, look at this here.
Yeah.
It clearly tells you that it's correlate with definitely with your lipid, with your calcific plaque.
Hiripe. Hiripe,
Get 3.5, 3.5.
can we show OCD? Yeah, so this orange color is a AI detected calcium sheet. And AI said arc of the calcium is 230 and a maximum thickness is 1.0. So the Abbott OCT can detect the calcium sheet. But the point is that some part of the calcified nodule, AI did not detect it because it's different from the calcium sheet. Acoustic shadow, you cannot see the thickness. So still calcified nodule detection, we need a human eye. So
Look, this is the same language somebody actually did mention that although kind of helpful, but still requires, I'm quoting it, still requires expert eye to confirm. One thing which I'm just noting, Kiski, is that we don't give it enough credit all the time, but look at the developments on the OCT. I mean, just the metrics of measuring the calcium, the total angle, the maximum thickness, there isn't much of a guesswork left here. It's calibrating it beautifully for you and incredible images.
yeah, so
It cannot calculate thickness.
Ah.
All it can do is arc
Right.
and length. Yeah, you have to be careful. Yeah.
So another taking you further into this. This sounds
No, I have to do IVL.
very important. This is Dr. Nikhil Jha, and he wants to know what is the difference between nodular calcium versus calcific nodule.
Remove it. Disconnect.
Yeah, that's the issue of the term. Now, recent paper said all calcified nodule, but the difference is eruptive or non-eruptive. The difference is the surface. If the fibrous cap is intact, then we call non-eruptive calcified nodule.
Yeah.
But
The calcific nodule is the new terminology for the nodular calcium of the past. Simple.
Got
You know
it?
what? Get me the OCT.
Nikhil,
Do we need
all
OCT
clear
now or
for
we'll
you,
do
I
OCT
hope.
after
Later.
balloon is there.
after balloon
Yeah,
we'll do
we
it,
have a lot
right?
of presentation,
Yeah.
yeah.
I mean,
Yeah.
absolute emergence of so many questions. In fact, more than questions, they are commenting for or for not IVL. And I can tell you more of them are suggesting or feeling that IVL is the additional technology needed here. But just to whether we use or not, but fascinated by the collective thinking of our audience, and thank you all for paying attention. These are exactly the situations which are make our webcast more and more valid to all of you.
And just to say that, yes, we listen to our audience and we are going to use IVL also, particularly in the mid segment.
Now first
Okay.
let us do OCT. We have to show what the OCT is showing.
Okay.
The algorithm that we have created. Okay, go up here.
The Rota wire is still there. See that? It's kind of providing us as a buddy wire and a little bit of modified cutting balloon.
We definitely
blade.
will need Godzilla here.
Yeah.
Get the stand down.
Yeah.
So, but
Go
right
to
now
mid
let's keep
segment.
it. Yes, right here. Get the OCT ready, right? Okay.
So this is the 3.5 12 or 15 balloon?
15.
15. And we are going to 20 atmosphere.
Okay.
Open nicely.
Yeah. So I don't think you'll need IVL.
Yeah,
Let's do the OCT.
Good.
Okay, go up there.
Open the guide liner also. Good.
We
There's no
don't need
disease
it.
there.
Yeah. A long
Okay.
Okay, so we are ready with the second round of OCT.
Okay.
Yes, I think that will be a enormous determinant in anything we do. I get a sense, Anu, just from your the last 2 or 3 use of the balloon that you think it's going to be just fine. We probably do not need any further ablative technology.
I say cine
Yes.
inject. Cine
Now
inject.
this is Dr. Mahmood Al Rais is putting me in a challenging situation. His question is very interesting, but I'm going to read it exactly it is so that I don't lose the message behind it. Is eruptive nodule sort of natural spontaneous calcium modification so that the stent expansion is predictable than non-eruptive one? Now you understand my dilemma reading that question.
Yeah. No, the
He's
whole
kind of
question,
right. I think he's right in his thought process.
Yeah, so but the overall, what they found, the calcium content in the eruptive versus non-eruptive is not different. It's only the discontinuity. Now, is it because of the acute coronary syndrome versus what need to be seen? Second point was that eruptive calcific nodule, you will say that, you know what, maybe you can get a better lumen in the eruptive calcific nodule. We presented one data on the eruptive versus non-eruptive. Actually, you can get a better lumen in the non-eruptive versus eruptive calcific nodule.
Hold it.
Check the path.
Okay, let's go to real stuff now.
One
Hold
second.
on. Right? Okay, no, there is the.
We're doing the IVUS again. OCT again, sorry. OCT.
Okay, now you say inject, I'll
Okay, 1 second.
go at that time.
Enable.
Yeah.
1 second. 1 second. Calibrating. 1 second. Yeah, please cine inject.
Amazing
Yeah,
images.
Yeah,
Amazing
beautiful image.
images.
Yeah, you can take it out.
All right.
Again.
Let's evaluate two lesions. One is the distal RCA,
Yep.
and the second lesion is of the mid RCA, that calcific nodule.
Sure.
Although there was a small calcific nodule distally also, it was just more of a calcium. So just to come back to the question of Jha, that in the past we used to call calcific nodule. Now the nodular calcium is the same terminology now.
You look at your core edge line.
Okay, because very tortuous
Huh?
lesion.
Why?
But, tortuous lesion, so I can check later. But anyway.
No. Do the core edge. Go back.
Take the pacemaker out. I think pacemaker.
Pacemaker is a trouble?
Yeah.
You think pacemaker is
Yeah,
giving you that?
that's also the issue.
Take the
Okay.
pacemaker out.
Well,
I'll
cross
We don't need a
sections.
pacemaker now.
So yeah, I will show you from the distal RCA.
No. Okay, I took the pacemaker out. Do the core edge again.
No.
Oh, cannot. There was cine. Waste.
Yeah, well, Dr. Kinney.
Why is the pacemaker any issue with this?
No. You see that a little orange line? It is
Oh, got
taking
it.
that.
Yeah. That's what I was
Yeah.
thinking. Okay.
So
Yeah, I see a lot of calcium.
AI is AI, but you still need human brain. See that? It's telling us.
Yep. You don't need to stick the AI.
Okay,
So-
tell me how many calcium fractures you see now.
Yeah. So
How many?
This is the mid part of the 360 calcium lesion. You see the big fracture here and a small fracture here. So at least two. At the proximal part of the proximal mid RCA. So now come to the calcified nodule part. Yeah, this is the calcified level of the calcified nodule.
Huge difference.
Yeah, and there is also the intimal damage. This is not the calcium part. The other part of the calcium nodule part. I mean, kind of a dangerous modification. Risk of the population.
You know why that risk of has happened at Kiski? Why? You have a nodule, but there's no calcium on the opposite wall.
Yeah, because we used a big balloon like a 3.5 or something.
Yeah.
So then
So
it
that's
has a
now
modification.
you see the normal so-called vessel, you already see little disruption. So what he's trying to tell us is simple, that if you become more aggressive here, there's a risk of perforation.
Yes. And
So-
also the distal RCA has a multiple calcium fractures. So distal RCA also has good modification. This is kind of like a medial dissection in the distal RCA.
So that's another thing we also keep seeing. When you have a nodule, you have this thick calcium plate, you often see some dissection at the edges of the plate.
Yeah,
right?
exactly.
And we see that more often when IVL is used.
Anu, there is both to you and to Kiski, there's this other observation I made that at the area where you ablated the nodule, it now gives you a sense as if there is another nodule on the contralateral wall. See, there you go. It looks like that wasn't there before. There you go. On the extreme, on the 3 o'clock position.
No, that is
Yeah,
a
No, that's a nodule.
Yeah, just a rotation of the image.
Yes.
So,
Right.
Rotation of the image,
That's
yeah.
what
Yeah,
it
yeah,
is.
it's the same nodule.
That
Yeah,
explains
yeah.
it. That
And
explains it.
now MLD was 1.0, now 1.7. So well expanded the area. Yeah.
It's time to stent.
So remember, this is the one was 1.07. Now it's a 1.7.
Yes.
You got a little more gain compared to the burr of 1.5. So lumen was more than 1.5 because of more of a wire bias. It probably shaved it. And so exactly at that lumen, that area of the maximum calcific nodule thickness, it was 1.07. Now it's 1.7, which
Yep.
is good.
Yep.
And that is what I tell everyone, that many times the wire bias of the rotational atherectomy is actually works in our favor, because it cuts into the more shaving and cut into the lumen of the basically vessel wall. Now we need to take that wire out. You need a guideline, Godzilla now or later?
What is this?
Yeah. So now question is, let's talk about that. Do we need to do IVL at the mid area or not? How much shaving which had taken place? Take this wire out. Rotatripsy
Yeah.
for the mid.
I think
So-
it's enough.
Go to the mid
Based on the imaging,
Yeah.
no.
Why? But no, tell me, what is the reason not to do IVL at this time? Let's ask our you and OCT expert that
Okay.
what is preventing you. Means by what we have, the lumen enlargement we already have. We saw the fracture in the calcium.
Yes.
Is it enough, or should we combine with IVL? That's my question now.
Yeah, of
It's
course.
enough.
Why?
Yeah.
So go back to
Based
that
on what?
picture.
No, my question is
based
based on
on the
what?
imaging, we'll go back to the imaging exactly Kiski at that nodule level.
Yeah, right here.
Yeah, this is like a medial injury. So
Right.
this more aggressive proliferation might cause a plaque perforation. So I think it's enough plaque modification.
Okay.
And,
Now,
yeah.
second question. Good, very good point. Second, in this nodule, do you see any fractures in the calcific nodule?
It's a very good
You barely
question.
see fracture in the calcific
Because-
nodule. Where you see fracture is
I
in the
said, no,
plate.
we saw
on
that.
the plate.
Yeah, my
so what
question-
you see a little disruption, which we already saw the disruption in the nodule. Go back to the nodule, because what you do is you shave the nodule. That's what we published.
Right.
That when you have a nodule and then you're doing OA or Rota, that the top, the peak of the nodule is shaved. That's all you do. And then your plate around it is where you will see some cracks,
Good.
which we see all of it. So what me and Kiski are telling, I think based on the imaging and angiographic, what we saw, the balloon, that it is a good modification. We can just stent it now.
Good. So very good point. I think and that's we are going to show in the paper with the case illustrations which Anu just highlighted. My second question is, this is the nodule. What if, and let's see it now, that if you do IVL, are you going to cause the crack in this calcium of the calcific nodule? That's a question.
So, but
Yes or not?
no, it's tough
No.
to see the calcium fracture in the calcium nodule because
Yeah.
calcium nodule consists of the other lipid or old thrombus or fibrin. So even by the OCT, we cannot see the clear fracture in the calcified nodule. Calcium sheet, we can see the beautiful fractures, but nodule still limitation of the OCT imaging to see the clear fracture. So different like morphology, nodule and the sheet.
All right, so good. So let's show that audience. We're just going to go make a 3-4 hour IVL at that area of the nodule only, and we do a imaging there again. Yeah.
Okay, let me tell you one other thing.
Yeah.
Go back at the nodule and give me the diameter.
Yeah, go.
I'm
Okay, right,
there
right,
is
right, right,
another
right. Yeah. Diameter
another
there.
concern which several people have raised. I didn't notice it.
Yeah.
At least 3 or 4 people
No,
are
no, no.
talking about osteal disease. Was there some concern in the osteum? I didn't see anything.
No,
No,
Not at
it's
all.
not
Okay.
CLDC, no.
Yeah.
Diameter is, give us a backside
1.7.
diameter.
Here,
MLD is
1.7. No, nothing, no
1.7.
osteal disease, right there. No osteal.
Nothing at all. Okay.
Okay.
There is
Yeah.
proximal disease 30%, but we are not worried about that.
Yeah,
Yeah,
proximal, it's
proximal
like
RCA about 30, right?
Yep.
Yeah.
Area is good.
Okay, so diameter is 1.7.
Yeah. And let's see if the one can we deliver the IVL. That's first thing, without using the guideline or Godzilla.
Yeah, of course, we cannot see exactly osteal lesion by OCT because we need to engage the guides.
Yeah. And remember, OCT is not good for the osteal lesions anyway.
Yep.
Now, the delivery of the IVL is a little challenging, which is not unexpected. And remember, there are a lot of new companies. There are 3 trials that are starting. Actually, one of them has already started for the new IVL catheters. So by year end, of 2025, they will have 3 other IVL catheters available. One of them is with the laser IVL, and they're called fracture trial, and we'll be part of it. And so, keep the 3 other companies are involved in the manufacturing the IVL, because such a big, huge market and much needed. Yeah. So we get Godzilla. We have guideliner or Godzilla? Guideliner today. Okay.
I think as much as Samin, you mentioned about there being a proliferation of companies
Go. I told them.
using different synergies of ablative devices. I think to me the real challenge is to make the catheter more passable and flexible, and to somehow lower its profile without losing ablative power.
That is correct. Yep. Absolutely.
And another question is very fascinating questions today. You know, people are end of the year is generating a lot of intellectual stamina. And here is Nikhil asking, will we get forward-looking IVUS?
Okay, answer to that.
Or
Not
Kiski?
that Kiski.
Yeah. So far
is
we
there
don't
a
have-
forward-looking IVUS coming out?
Yeah, I
Give me
didn't
a
hear
balloon.
that, but I think that's good for
Kiski,
us.
Kiski, I want
CT
you.
procedure. Mhm.
No, Kiski, hold on. Listen to my question.
Yep.
I want you to make a forward-looking statement about a forward-looking IVUS.
Yeah.
Yeah, so I mean, forward-looking IVUS is going to go like a total occlusion lesion, like a CTO lesion. So maybe that kind of cases, maybe that might help. But if it's a crossover lesion, maybe we don't need forward-looking IVUS.
No, but the forward-looking IVUS could be very useful for osteal lesions.
No, don't connect, guys.
No. Osteal lesion we can see by the IVUS because we don't need to engage the guide. OCT we cannot, but IVUS we can see the osteal lesion. So then we don't need a forward-looking.
More question, and this is not, Samin, you may have known him, Dr. Shantanu Deshpande.
Yes. Oh, yes.
Oh, you know him. Okay. Because I don't remember him asking us before. He may have been. Why do eruptive nodules reach stenosis more than non-eruptive? All excellent thinking today.
Eruptive nodule, think like a volcano.
Yeah.
So, you know what is a volcano, right? Even though, so it is a volcano, it will
Very
quieten.
active.
It will quieten, then becomes active. It is quietened, then become active. And just like what Kiski said, when it's a non-eruptive nodule, it's full of calcium. So I think it is nice. It's like a nice plate of calcium. There's no risk. The other thing is, with the eruption, it is not just calcium. There is lipid. So when there is lipid, there's a risk of disruption, and again it keep becoming active. So that is the difference. Just remember as a active volcano.
Yeah. So, I mean, other question comes down to that one is the quiescent, think about the plaque, one is the very active plaque. Basically what mentioned about of the volcano type situation. So this is again, all these are, this all coming onto the limelight now. We didn't know much about all those things. We are enough to knew about the nodular calcium, then become this calcific nodule. And now we are learning eruptive, non-eruptive. Soon will be some different variety.
Look, I think all of this was there. Our knowledge has been enhanced by imaging.
Yeah.
Imaging is making such a difference in the way we are interpreting it, even viewing this. And
OCT ready, okay? Because now I have to do OCT again.
Okay.
Okay, go.
So this is the 3.5 IVL, and we are going to the 6 atmosphere because it's a big vessel.
And not unexpectedly, you needed the guideliner.
Yeah. And we knew with the stent you needed a guideliner anyway, so that's okay. What is the distal dissection or calcium?
Calcium.
Yeah, it's become so much more prominent in this view now.
Yeah.
You see that even on fluoro, you don't see, looks like it's a good expansion. Okay, go up here.
Yeah.
How many trains did you use there?
Right now the one, let's see a few more we'll do. Maybe we'll do a 3 only. 6, go to 8, and then now down. Question, you want to pull back 2 millimeter?
No, this 10
More.
to them, no? Proximally, how far you want to come with the stent? Okay,
this one,
go.
yeah.
Huh?
Yep, this is it.
That moderate disease, will leave it.
Yeah, proximal will leaving moderate disease, yeah. Angle, that will leave moderate. And 48 will not cover, you need 2 of them.
Distally, we put a 3.5 distal
Yeah,
RCA.
you can.
Okay. So we will take a 3.5,
38.
what, 38.
38. And then 40, 23. Good.
Samin, I can report to you that this is such a joy to report such intellectual powerhouse of people watching the case today and shooting us with all thoughtful questions, excellent discussions. And here is Dr. Mayank Yadav talking. What about the cutting balloon in play instead of IVL? All
That is
good
correct.
thoughts. All
Yep,
good
all
thoughts.
the good thoughts. Yep, that is true. So could be a combination, but whether cutting balloon, but I think the rota cut, and we'll show some data, that rota cut really didn't pan out with the better MSA. We did the rota cut trial, high pressure versus the cutting balloon didn't make difference. So whether IVL will make a difference is still there's no trial for it, but I think this is a reasonable to look into that aspect.
And there is no letting on the pressure. So it's almost a retrospective question which has come through. If the images were looking so good on OCT, why did we use IVL? That's why I said retrospective. So initially there was a chorus of people wanting IVL, and now there is a rethinking, which often happens. You have challenging cases. You determine a strategy, and then you pause and say, "Look, was it needed?" I think
we went through the algorithm very
right.
clearly before we even thought about it. Yeah. And that is the algorithm that we published, and that's the algorithm that we are going to be teaching continuously. I think what is important is what we need to teach right now is, yes, we can handle calcific lesion. Now we have so many devices, exactly what the discussion is happening, which device to be used when, and what kind of synergy we need to do with these cases.
Since we have talked so much about the algorithm, is it possible to show it again?
Yeah, he's going to discuss.
Okay.
Yeah, we'll show. No, we'll show it in our
That was the
presentation.
bridge
Yes.
between me and Kiski, the calcium algorithm. Okay, ready?
Yeah, can you check the path?
More questions. Did you
good.
use the guideline or coast?
1 second. Can you show the OCT on the screen?
Now, do I need to pull back?
No need.
Hold on.
Philippe.
Can I pull back? It's okay, right?
Yeah, okay. Enable. 1 second. Enabling.
You know what?
1 second.
Wait. Okay.
1 second. 1 second. Calibrating. Yeah, cine inject. Yeah, beautiful image.
Was it the coast they're asking? Did we use the coast? Asif, their question is, which guideliner did we use?
Yeah.
So yeah, it's a coast, they're saying.
Without the pacemaker, college worked.
Okay, nice. Without the
that
pacemaker, we have a finally beautiful courage.
There was too
So-
much color from the pacemaker. Okay.
Yeah.
Kiski, show us.
Yeah,
Looks
Okay,
That's
right
beautiful,
there, right there. Yeah,
very
that's
nice
where the
lumen.
nodule was.
Yeah.
Yes.
Yeah, looks the fracture is like bigger, like a deeper.
Yeah.
Here, the 11 o'clock, like a deeper.
See that is what we predicted when we do IVL. Look at that, how there is a deeper,
Uh-huh.
almost reaching adventitia soon.
Yeah, and this part of like a surface of the causal nodule is shaped. This is the first Rota did it.
But look at the dissection.
Yeah,
Look at the length of the dissection
but
is almost close to 70 degrees.
yeah, this is a medial dissection. This is like a dangerous.
Big
one.
flap. Yeah.
But we are lucky it's not population yet.
Me
so-
and Kiski predicted this beforehand, that this is what's going to happen, and exactly what we see now.
Yeah, but definitely.
Go back to that other dissection flap there. Come back.
Okay, now come to the
Little bit.
distal
No,
part.
no. Go near the lesion.
Oh, sure.
Distal. Come back. Back.
Bring it here.
More. Yeah. Right there
Show
again.
this slide. One slide.
Yeah. Yes.
So
yes,
let's
yes,
talk
yes.
about the
Yeah. Yeah.
purpose was, is there a fracture on the calcific nodule? That's the thing with IVL.
Not fracture, we are reaching the adventitia.
No, but no, cannot be in the nodule area. Maybe the other side.
Yeah, other side is
Other side.
like a
Look at that. Look at the
medial dissection.
dissection.
Well, yeah.
Okay, but
60
magnify
degrees.
the nodule cap. Is there any fractures or no?
So, Dr. Sharma, as I told you, so we cannot see the fracture, like a limitation of the resolution of the OCT for
I
nodule.
see. Okay. All right. So,
But then go back where we have the deep, very deep cuts.
Deep cut
Almost
is like
a big crater. Yeah, right there, right
yeah,
there.
this is a 360 proximal RCA part, 360 calcified part, like a more deeper, bigger fracture. So I think it's ready to stent.
Okay. So with that note, let's say, because we're talking about the calcific nodule teaching, now tell us what stent you're putting so that I can show that slide now. But tell us what stent you want now. Okay,
No, 3538.
Good. 3.538.
No, I don't know. We may have to get this further down, no? May not go. 38.
Okay. Now see this now. Calcific nodule, which we talked about, both eruptive and the non-eruptive. Eruptives are less, usually by incidence. Active can cause acute coronary syndrome, stable, non-eruptive. And of course, interventional strategy, we'll talk about it. We already done. Mostly deformable, greater stent expansion in the eruptive calcific nodule, and more TLR, and worse prognosis because of the active plaque. So you see this one, a nice paper really describing those two, and part of that we'll describe also.
I mean, here is another
Go to the angiogram.
fascinating question posted by Dr. Jha.
Yeah.
Recently, people are using only DCB. Is it wise to leave these dissections when using a DCB only strategy?
Very
Obviously
good point.
not.
Very good point. So actually, if you go to the DCB, the strategy basically is that if you have a type 3, like a C dissection, little timid decreased flow, in those cases, even if you, because your lumen has gone down to less than 30, two things. One, use a DCB only when you have brought the lumen less than 30. Like this case could be okay.
What do you think?
Second, if you have a dissection,
Okay, take a
I would
picture.
say that don't use DCB, because large vessel DCB failed. There's no question. Some people are a little too crazy about DCB.
I thought DCB failed in about everything.
Well, in the small vessel, maybe an ISR,
Right.
but definitely in the large vessel, no. Clearly, the DCB is no good for
now
the
that-
large vessel. A small vessel, diffuse,
that.
and maybe ISR, but definitely not for the large vessel. Absolutely no. So this case, they should not be left alone, because that patient will come back,
some dye.
guaranteed, and all the trials have shown that
Okay,
way.
good.
And they're not going to do any
Go up.
trial of the large vessel DCB. DCB is only for vessel size 2.5 and below, and diabetic patient
Yes.
probably has little extra benefit of DCB
Stay.
versus
Stay,
non-diabetic, and the third group will be ISR. Yeah.
Anu, you've been singled up for a compliment and recommendation. This is Dr. Shoaib Zia from Pakistan, and he quotes exactly, excellent demonstration, Dr. Kinney.
Beautiful.
Thank you.
Thank you, Shoaib. Delighted to have you join us.
418 or 23? Use 23.
Long. No? Hold on.
Yeah.
Okay, take a picture.
What
now.
a-
Slow.
What an absolute joy to conclude the year with such a robust audience.
Yeah.
Slow.
Slow injection. Good. Beautiful.
Beautiful. Okay.
We can post that a
4-0.
little bit later. Yeah.
Yeah,
But let's do the
4-0.
proximal. 4023.
And then final OCT ready.
Yeah.
You start. Keep going.
Okay. So with that note, I think we're putting a stent, and final OCT will show it. Meanwhile, we can start getting on to our academic presentation, and then we'll show the last OCT and angio in next 5 minutes. So if we go with this case, we are done. Planned as we talk rotatripsy. This was appropriate case because of FFR of less than 0.8 on the CT FFR. CT and invasive FFR both. Now, the 2 points this time, we said let's put the publication from Mount Sinai Cath Lab. And we say long-term outcome of the intravascular brachytherapy, then RAOA IVL, which we talked about, in the calcific nodule, calcific lesion treatment algorithm, predictors of stent under expansion in the Rota cut trial, and the impact of major bleeding after left main disease revascularization. And the Anu will talk about the late breaking trial she presented on the transcriptomic gene data of the yellow 3 study. And focus review of the month again from Mount Sinai, drug coated balloon for coronary artery disease, biggest review of the DCB for the treatment of coronary artery disease, native and ISR in the JAMA cardiology is online at present. So first one, very simple, IVBT for multi-layer instantary stenosis, long-term outcome of like 40 months follow-up and accepted 16. In Euro intervention. These are we probably had the largest in the recent era, largest IVBT experience. We compare our 453 cases, which is the 70% against the control, which was also basically was the multi-layer ISR, which did not get the IVBT. So control was no IVBT, against IVBT 70-30. These are the 12.4% of the total DES ISR at Mount Sinai, and we followed them for 3+ years. Majority of these patients were acute syndrome, non-acute syndrome with a stable angina and unstable angina in about 34. So basically, we do quite a bit of plaque modification in these cases with a rotational atherectomy almost in 1/3 of cases. And key is teaching with the IVBT, avoid putting second stent. And look at the cases of 500. Only 2 patients require restenting. Only 2. Compared to even you had 2 layers stent, we had almost in 1/4 we had to put a 3rd layer of stent. You can see. And complications are very minimal, overall procedural success. And this is the key. The central illustration of the paper is that what happens to the long-term outcome. A lot of people say that there is a catch-up phenomenon on the IVBT, and now I can tell you at Mount Sinai data, we did not see it, and this is the largest study. See the almost 1100 days follow-up that you have a benefit of the primary endpoint of the death, MI and TLR at 3 years with a p-value of 0.0172. Now we say, well, okay, let's see, maybe the benefit was only in first year and you lose it there. Now answer there is no. See that we did a landmark analysis at 1 year, there is still a benefit, but maybe less. But still there was a benefit after 1 year. Yes. So therefore, although you could say the slight catch-up happens, but never as good. This technique remains. You see here numerically lower MI rate, TLR rate, and the MACE as we have spoken about. And more important, people worry about the stent or device thrombosis was 0, 0, 0 in IVBT cases, and 2 cases we have in the non-IVBT cases. So this is the central figure. So overall, I think the IVBT is a great treatment for the multi-layer DES ISR. We also published this paper, that is the predictor of suboptimal lumen expansion following IVL for coronary ISR, whether it's because of the calcific stent under expansion or calcified neoatherosclerosis. And we can see there that neoatherosclerosis really is one of the factors that you cannot expand the stent completely. And then second is if you're 2-layer ISR, you have a lower lumen. Look at the odds ratio of 16 once you're 2-layer. Then this, which was the discussion today about rotational, orbital, and IV intravascular lithotripsy. Kiski actually presented this in a European society. And then we also presented part into the TCT, and now the paper basically showing that if you take all cases, and this is because we understand better now with the OCT is better predictor or understanding for the calcific nodule. Calcific nodule is present in about 30% of cases. See that of the 158, 54 were calcific nodule and 104 were without calcific nodule. And those calcific nodule 54 were treated by rotablation, orbital, and intravascular lithotripsy. And many of them were combined with the rotational atherectomy and lithotripsy. And this is basically we talked about rotablation does shaving the surface of the calcium, integrate. OA is the sanding the surface of calcium with the side of the crown, bidirectional, and IVL, calcium fracture shaking for the stent expansion, and we have shown all 3 of them in this eruptive calcific nodule which we saw today, and of course difference in non-eruptive. Basically, as far as the QCA, we didn't find any difference in terms of the acute lumen gain. Was about 1.5 in all. The biggest difference which we saw, and I am part of the lot of discussion, the calcium fracture. We saw much calcium fracture in the rotation, the IVL, second one in the rota, and OA was 11. But look at the IVL. Very high incidence of calcium loss, you can say almost everybody. And the multiple calcium fractures, the more than one in the IVL group, as you can see there,
Can't
and
get
other points were not different, basically, and these are the illustrative case examples of the IVL, RA, and RA plus IVL showing that further lumen gain. But as you say, I've showed it, there is no difference in terms of the clinical outcome. Overall, procedural outcomes are excellent. Multivariate logistic regression model showed stent under expansion only one thing, that is the maximum calcium arc. Other factors were not important, and this is the basically central figure, which led to the algorithm for coronary calcific nodule. And this is what Annu was talking about, that you do the imaging, and imaging, you can do both calcific nodule by the IVUS as well as by the OCT, but OCT is more, a little better in identifying the calcific nodule, eruptive versus non-eruptive. I think it will be tough to define eruptive versus non-eruptive on the IVUS, but from the OCT, and if your calcium arc is more than 270 and your lumen is less than 1.5, that's where you start with the smaller bar. And that's what the point was made, 1.5 bar we use or OA. And then consider IVL in some cases. If the lumen is more than 1.5, then you can go with the large bar or high speed the orbital atherectomy, and IVL is plus minus. You probably would not need it because you use the large bar. Now, if the calcium arc is less than 270, so therefore, and the lumen is still remain less than 1.5, then your strategy remains the same, but probably you don't need IVL. If you decided using the rotational orbital atherectomy or the IVL, any one of the strategy can be used in these cases. So then the last one is that if you have no calcific nodule, then of course what we usually do, Rota OA IVL, and if there is very little calcium, then you always go with the non-compliant and compliant balloon, and followed by intravascular imaging to reassess the calcium fracture for full balloon expansion and the DES implantation and stent optimization. So this basically is a great paper. We also have a nice review article of progress in cardiovascular disease, which also has a very good impact factor of 10 plus about the calcific coronary lesions imaging, prognosis, preparation and treatment, and state-of-the-art review. Very extensive IVUS, OCT, calcific plaque, nodular calcium or calcific nodule, eruptive calcific nodule, and rotational atherectomy, orbital, where you use advantages and disadvantages, and then various trials of this in the calcific lesion, starting with the first one, URBAC, Artist, Rotexus, and Orbit group, orbital atherectomy, the Laser, Lava, Ambro. What is not included here is the orbital and rotational atherectomy, which is the DERO trial, because this paper was done before that. Then we also have the trials of the lithotripsy, basically the disrupt CAD group and combined strategy, and so Rota cut. So these are plus minus of all devices, balloon, rotational atherectomy, orbital, laser, and intravascular lithotripsy, and basically many times you have to combine them, and this is the algorithm which we have created, similar to part of that which we have shown earlier, that basically based on the degree of calcium, and superficial or deep calcium is very interesting, that we define that if your calcium is into the vessel wall, superficial calcium is categorized if the leading edge of the calcium appears within the shallowest 50% of the plaque thickness. If it is 50% superficial, if goes further, that's a deep calcium. And the treatment strategy, and this is we have made this same very nice for people who want to use it for their teaching purposes. So this was a very nice review article, because the calcium has really come up to the mainstay of treatment of many cases. Then we did a Rota cut trial of the 60 patients, rotational atherectomy followed by high pressure versus rotablation plus cutting balloon, and we said what give rise to a stent expansion. It means 80% of the MSA compared to the average of proximal and distal, which occurred in 55% of these cases, 45% did not, and basically the predictor of the stent under expansion, you can say, is the vessel size diameter less than 3.5 and lesion length, and you're showing here, and there was a trend that the cutting balloon has a slight trend about the better stent expansion. So there was a less under expansion using the cutting balloon, but overall no difference. This is our central figure. So these are the various trials ongoing. We actually had given proposal, which is kind of approved now. We will be starting for the nodular combination of the little change in the comparison. It is being the IVL versus Rota plus IVL, right? So initially we wanted to do comparison, but this is little modification now. What has been approved is IVL versus Rota plus IVL. And then the last but one publication was major bleeding and mortality in revascularization of the left main disease. That anytime you have a bleeding, higher mortality you can see versus no in the Excel trial, 5-year 8 versus 15%. And very important, basically what we learned that the in-hospital and bleeding is more with cabbage, out of the hospital bleeding post-discharge is more with PCI. We know that all because of longer antiplatelet therapy. Then the risk factors are usually same: female, anemia, patient with the underweight and additional disease, and post-discharge is the patient who are on atrial fibrillation, CKD, and diabetic. So this basically is a central figure that you have a more bleeding in the cabbage group compared to PCI group, and the PCI more post-discharge, cabbage more in-house, but any type of bleeding is associated with a higher cardiovascular and overall mortality. So this basically the paper, one of the papers. So now we come to the main one, which Anu is going to talk about, which he presented as a late-breaking trial of the transcriptomic signature and predictors of evolutive curve added to maximum statin therapy based on the intracoronary plaque characteristic yellow 3 study. Anu?
Yeah, this was presented in AHA as a late-breaking clinical science. So if you, study was actually sponsored by Amgen and partially by Abbott Vascular. So the thing, despite high-intensity statin therapy, a considerable residual risk of cardiovascular event remains in patients with CAD, and PCSK9 inhibitor has reduced this residual risk. The aim of yellow 3 was to assess the effect of 26 weeks of evolocumab on coronary plaque morphology using intravascular imaging and peripheral blood mononuclear cell gene expression analysis in patients with the stable CAD. So we took patients with stable CAD who were on maximum tolerated statin therapy. They underwent angiogram, non-obstructive disease was identified. They then underwent OCT to understand lipid-rich plaque, who also had minimal fibrous cap of less than 120 microns. So lipid-rich plaque means the lipid arc had to be more than 90 degrees. They were enrolled in the study. After that, they just had a NIRS IVUS done. All of the patients got evolocumab 140 milligram every 2 weeks in addition to their statin therapy for a total of 26 weeks. 110 patients were enrolled. When they came back for a follow-up after 26 weeks, we repeated OCT NIRS IVUS of the study lesion. We had blood collected at baseline and follow-up for PBMC analysis. So the primary endpoint was change in fibrous cap thickness and change in the maximum LCBI of 4 millimeter, and that one I presented in ACC of 2023. Then the changes in PBMC gene expression is one I presented at the AHA that just happened. So the total cholesterol and LDL between baseline to follow-up, if you see there, significant decrease in cholesterol and LDL. But between baseline to follow-up, there was no change in C-reactive protein. So the primary imaging endpoint as shown here, if you see the fibrous cap thickness, the entire group or the entire cohort, a significant improvement in the fibrous cap when they came back for follow-up. Similarly, a significant decrease in maximum LCBI of 4 millimeters of the NIRS. So baseline 782 of the lipid LCBI came down to 235. We call it a melting butter sign. We then identified who are the patients who are responders. So responders were patients with increased fibrous cap thickness and a decrease in maximum LCBI at follow-up. So there were 80% responders and in fibrous cap and 76% in LCBI. Non-responders were identified as patients who had no change in their fibrous cap when they came back for follow-up, or no change in their LCBI, most people had both of it. So, but if you see, as shown in this example, fibrous cap is the same 50 micron, LCBI actually increased little bit from 586 to 690, but look at their LDL. LDL was 78 at baseline. On therapy, they became 7. So you take a biochemical change, you see that LDL has changed. So this is what we think, that in these patients, that there is, okay, we are treating the patient, LDL has changed and they will not have any further event. But you can see about 20% of them non-responders when they come, when we see their plaque inside the body. The question is, was there a change in the total cholesterol and LDL between follow-up and baseline and follow-up in the responders versus non-responders as shown here? No, everyone responded biochemically, but there is something different in their plaque. So what is it that is different in these patients? A total of 104 patients had imaging and transcriptomic data available at both baseline and follow-up. What we did was the bulk RNA sequencing, okay, not individual cell, but the complete bulk sequencing of the PBMC. 1493 differentially expressed genes were identified. And as you see there in the red, 922 were upregulated and 571 were downregulated. And with the significant p-value, you can see at the side the significant p-value between baseline to follow-up, and you see the heat map. The heat map is the one that shows that between baseline to follow-up about the various genes. Also, what we had done was the ingenuity pathway analysis to understand the key molecular pathway associated with plaque stabilization after 26 weeks of evolocumab. And we use the canonical pathway to of the 1492 genes, and what we found, the most important genes that were upregulated, as you see there, was the orange bar, and those were the genes that were associated with pathway responsible for electron transport, ATP synthesis, oxidative phosphorylation, mitochondrial translation, and crystal formation. All of these upregulated genes essentially showed that there was an improvement in mitochondrial function. And the so-called mitochondrial dysfunction pathway, if you see that in the blue, it was downregulated. So the other downregulated pathways were binding and uptake of ligand by scavenger receptor phagocytosis, cell surface interaction at the vascular wall, which is the most important pathway responsible for the plaque formation, and I will go over it a little later. And then lot of immune cell interaction between various, I would say, immune cells, all responsible for inflammation. So these were all these blue pathways. These pathways were downregulated. The other important upregulated pathway was the pathway responsible for protein synthesis and cellular response to stress, as shown by the eukaryotic translocation initiation. This was responsible for cell survival. When cell survival improves, apoptosis decreases. When there is a decrease in apoptosis, there is decreased plaque formation. So other gene associated with increase in fibrous cap in the entire group, what we found was 15 upregulated genes, and most of these upregulated genes, as you see that in that what we call as co-expression network analysis, gene responsible for smooth muscle cell contraction, which is very important for plaque stabilization. Other downregulated pathways were pathways responsible for IL-6 and TGF-beta signaling. Both these pathways are responsible for inflammation. So so-called inflammation responsible pathway was downregulated. Now the question comes, what is the difference between fibrous cap responders versus non-responders? So we analyzed them separately. So fibrous cap responders had 2068 totally differentially expressed gene. of that 90 significant pathway. All are orange pathway with significant p-values. And what were those pathway? Like we showed, is increased mitochondrial function, cellular response to stress, and increased protein synthesis. All this is important for the cell survival and decreased plaque. What was the issue with the non-responders? 301 genes were identified with 20 significant pathways. And of that 20 significant pathway, what we found was that X should be on the mitochondrial function, that the mitochondrial function was no different in non-responders. But the neutrophil degranulation pathway is upregulated. You see that the orange bar on the top, that equal to inflammation. And the PCV inflammatory pathway was downregulated. That pathway is responsible to decrease the inflammation. Then we decided, why is it that the responders have a better fibrous cap response? So we did a machine learning model to predict why the patients had a better FC of fibrous cap response. So there were 38 baseline genes that we identified under the ROC of 0.97. And these genes were mostly the genes associated with inflammation, wound healing, and mitochondrial function. Similarly, the genes that were responsible for LCBI reduction in this machine learning model, the prediction on the ROC was 0.85, and 71 baseline genes were identified responsible for inflammation, wound healing pathway, mitochondrial function, and extracellular matrix organization. So the common pathway between decrease in LCBI and improvement in fibrous cap in these patients was interleukin-1 receptor type 2, which was associated with M2 macrophage. And we all know M2 macrophage is a better macrophage compared to M1, which is responsible for inflammation. MMP9, that was another gene, and a CA4. And all of this essentially means the inflammation, neutrophil function, and mitochondrial function, that inflammation decreased, improvement in neutrophil function, and improvement in mitochondrial function. That's what we saw. So this is the animation essentially depicting the plaque regression. So if you see here, LDL comes in the serum. So then there is monocyte. Okay, the monocyte comes and adheres to the vessel wall. The monocyte undergoes phagocytosis, and then lipid uptake happens. Then there is foam cell formation. When all these things happen, increase inflammation and M1. What happens inside the mitochondria? Inside the mitochondria, the reactive oxygen species ROS increases. Because of that, the mitochondrial function decreases with decreased protein synthesis, and you see a downstream effect. All that happens. So we also know when all this happens, apoptosis goes up. When this happens, the lipid continues to build, the smooth muscle cell contractility decreases, fibrous cap becomes thin. You give avalucumab. First thing that changes is the monocyte addition stops, the lipid uptake, foam cell, everything goes down, inflammation changes, becomes M2 macrophage. Now mitochondrial function improves and also protein synthesis increases. With all these changes that happens, means everything is reversed. Apoptosis goes down, and what happens is the extracellular matrix degradation goes down, smooth muscle cell contractility improves, and the fibrous caps become thick, and the so-called lipid starts going down. So whatever genetic changes that we saw in their gene expression transcriptomic changes, we saw that in the phenotypic changes, which was the imaging, that essentially the lipid-rich core decreased and the fibrous cap increased and the macrophages decreased. So this one was the first of its kind study. So the conclusion of Yellow 3 was, in patients with stable CAD on maximally tolerated statin therapy, more intensive lipid lowering with addition of avalucumab resulted in beneficial changes in lesion morphology. For the first time, this clinical study demonstrated an association of plaque stabilization on imaging and improved PBMC mitochondrial function. So reduced monocyte adhesion and transmigration, decreased lipid uptake, recovery of smooth muscle cell contractility, decreased apoptosis contributed to plaque stabilization. So machine learning model predicted individual fibrous cap and LCBI response to evolocumab using baseline gene signature with very high accuracy. The models could help identify patients who might require alternative therapy and have development of personalized approach for treating CAD. This was the entire yellow team from Mount Sinai Cath Lab.
Beautiful. All right. So you learned that mitochondria is a big factor now. Mitochondrial is another organelle cell within the cell, really to the high level, and this going to the next level now. That what can we do? Can this observation be translated into the therapy? And this will always happen once you make a diagnosis, whatever it is, and then you find the treatment. So here, the diagnosis of has been made, particularly patients who are non-responder. And question is, can those genes be altered by some technique? So where are you in the future? What this will lead to the next step, and the more so for the therapeutic discovery.
No, first of all, what you do is resurfacing of the drug, what means that you can use this model and understand, is there a drug already which is available, either a pharmacological or non-pharmacological drug that is available that can change the mitochondrial function. There are a few things that are available, but not to the extent that we want. Otherwise, now we have all these gene signature, so we can identify them, go back to the bench, and see if there is any drug that can change the gene the signature of these non-responder patients. And also understanding is who should get statin, what is personalized medicine is, who should get statin, who should directly go to PCSK9 or any other therapy that we can think of.
Beautiful. Samir, any question on that?
Yes, a whole page of questions. And first of all, a few observations purely from my point of view. Anu, congratulations on this trial. This is massive. This is massive. It took me back to the reverse trial, which was done 25 years ago at Cleveland Clinic, where they had taken patients and performed a coronary angiography for patients on 2 doses of atorvastatin. 25 years later, you moved on to demonstrate the incredible relevance of all this work with evolocumab, and congratulations. This is a massive step forward, and of course, as you mentioned, it delineates exactly the role, who gets statin, who moves on to the next level. And I hope at some stage this would be compared to exercise also. Those were my observation, and congratulations. Many people have congratulated you, including Dr. Tulsi Das from Houston. Samin, to your first presentation regarding IVBT versus the question is, for a multi-layer in-stent restenosis, how would it compare with DCB?
Very good point. So yeah, so remember there are some data that if you have more than 2 layers of a DES I'm talking, not a BMS, DES, the DCB may not be that effective. So what we want to do now, because right now, if you do IVBT has been excluded from the DCB trials. I want to do dedicated trial of the patient with a double layer and then do IVBT versus DCB. So that's what we are looking into it. What happens when you have 2 or 3 layers? Whether DCB is effective at all or IVBT is the one to go for it. So this there's no answer to it, but I can tell you our personal experience, the cases where we have failed IVBT, we use DCB, results are not optimal. So since the agent trial has been approved, agent device, we have used at least 20 cases of this where IVBT has been used, and patient already have 2 or 3 layers. IVBT failure, they come back with a DCB we did, and almost restenosis rate is 30%. 1 in 3 came back within 6 months. So that's the data I have, but those are the IVBT failures, and I still think that there should be another the registry in the DCB trials, that ISR and ISR, which is after IVBT failure. All the 3 ongoing DCB trials, the magic, the solution and all, they have excluded IVBT patients because they know they are very high risk group and the device may fail. So that's one of the big issues. So we will not know yet, but I think we'll take next 1 to 2 years. And I would say that now the coding, we have the new device code as of January for the existing drug-coated balloon, and hospital will be paid for the cost of 5,500. So we, because of the new procedure code, NTP, and we'll be using more, and then we can do some kind of a comparison that what happens to the 2 or 3 layer ISR, whether you use IVBT or you use the DCB.
Wonderful.
And we can go our presentation also. Let me complete and then we'll show you this angiogram. Go to the slides, please. Because we had to show the last angiogram yet. Have we shown that or no? Yeah.
No,
so we are going to go there.
Yeah.
But let me just see that. So another paper is the JAMA Cardiology, the drug-coated balloon for treatment of coronary artery disease, a review. DCB, some people call drug-eluting balloon, and this has been approved. So basically these are the effect of various devices on the PCI outcomes. The biggest advantage of the DCB is it gives you homogeneous anti-proliferative drug delivery. It basically, the drug is connected with some kind of expedient which slowly releases the drug, goes into the vessel wall, and that cage-free and accelerates the arterial healing, preserves normal vessel anatomy and function, and offer potential positive vessel remodeling. And good for ISR, small vessel, long lesions, bifurcation, side branches, diffuse distal disease, and CTO. And and particularly high risk bleeding cases. So we have given the clinical indications, angiographic indications. Use is very limited in USA, but many places it's almost 1 to 4. But overall, I would say it's like 1 to 20. That if we are doing a 20 angioplasties or PCI, probably 1 is drug-coated balloon, or maybe it's between 10, 20 to 1 is the ideal ratio. And these are the trial of the ISR, the de novo 5-6 trials, with the majority of them for the small vessel. The latest one, the cage-free trial has not been included in this review because that all came out after this publication. Then what we have done is existing DCB technology, all of them which are available, various compounds, what is the excipient in terms of the type, the approval, non-approval, and then the trials in the ISR, DSISR, mixed ISR, and then de novo studies, all of them with their late lumen less, and so we have put that together. So that comes down to how do we work the DCB now? So DCB basically, first you select the vessel, do the imaging, and modify the plaque, either with a high pressure balloon or the scoring balloon, cutting balloon, open NCL, whatever, and then atherectomy. And after the atherectomy, your device has to be, you brought the lumen to less than 30%. You see that? You have to bring it down to less than 30%, good results. And if you don't have that, then you should put a stent. And also, if the same thing, your dissection, you have a person, the lumen narrowing, you have diastasis. Those cases, if that is there, you go with the DES. If not there, your lumen is less than 30, there's no dissection as we spoken, then you put patient with the DCB, but those cases should be the small vessel or a clinical scenario which we have seen. So basically the DCB, you leave it for 60 to 90 seconds, one inflation, and that is it. And then depth duration could be shorter. So basically what we did is that this is a nice review of one of its kind, except, the JAMA Cardiology, the impact factor now is 32. Great, the journal, and this has really put together. So let's go back to our take-home messages of the coronary interventional publication from Mount Sinai Hospital Cath Lab and DCB. Yes, IVBT or no IVBT for multi-layered DES, ISR, PCI, yes. Second is higher calcium fracture with IVL versus Rota or OA in calcified nodule. And then impact of major bleeding or mortality after left main revascularization, 2 thumbs up. And then PBMC gene expression of the plaque stabilization with PCSK9 inhibitor as shown by AK. Drug-coated balloons, by providing homogeneous anti-proliferative drug delivery with no foreign body implantation or residual polymer in the arterial wall, are emerging as a definitive interventional modality in management of certain sets of coronary lesions. ISR, small vessel, side branch, diffuse distal disease, STEMI. So it could be 15 to anywhere between 10 to 20% of your PCI patients. Then DCB, by limiting DAP duration, can also be beneficial in PCI patients with high bleeding risk. So you can stop the drug, the DAP within 2 to 4 weeks. Then their role in large vessel PCI against DES remains to be determined, as few studies, including 2 randomized trials, have favored DES over DCB in this setting. So large vessel, question mark, I would say don't try it. There is enough room for using this and go. So recent publication of the long-term outcome of the IVBT and no IVBT in multi-layered DES ISR has shown the following, except, that means all are true except what is wrong. Similar death rates between the two groups, similar MI rates between two groups, trend toward lower TLR in IVBT versus no IVBT group, higher device or stent thrombosis in IVBT versus no IVBT group, and lower MACE rates in the IVBT versus no IVBT group. Clearly, there was no device thrombosis in the IVBT group. Second, following statements are true regarding the results of the treatment of calcific nodule by RA, OA, or IVL, except clinical outcomes are similar between 3 groups, TVR outcomes are similar calcium fracture between 3 groups, similar acute lumen gain between 3 groups, and maximum calcium arc was the only independent predictor of stent expansion. Clearly, remember, fracture was different. Much higher fracture in the IVL group compared to our atherectomy of the RA and OA. Third question, following are the true statement about the trials comparing DCB with non-DCB strategy, POVA, DES, except DC is superior to non-DCB in ISR treatment. DCB compares well with DES in large vessels. DCB is a viable strategy in high bleeding risk patients. DCB should only be used when residual stenosis less than 30% is attained by balloon or atherectomy techniques. And DCB should not be used in setting flow limiting dissection. Clearly, the issue is B. So there B does not compare well with the DES in the large vessel and should not be used. So just to commit, claim your CME credit. This is at the end of the webinar. You can log in. Will take you about 30 seconds, and it will be available for next 24 hours after the completion of the webinar. Please, we encourage those who need CMEs. There will be a 1.5 CMEs per episode. So you can think about that you could have a 18 plus CME just by attending our CCC live webcast. With that note, I completed, and Anu just had to show the last picture with the OCT. Yeah. Show the last picture. Go back to the angiogram again. That's the last picture. Yeah, this is the last picture, and now going to show the OCT. Okay.
Like a huge residual block, but the stent looks expanded, and the MS is 8.0, and there's no malposition dissection. So yeah, proximal to mid stent is well expanded and no dissection.
Okay.
All right. With that, we conclude our today's presentation.
Samin, a couple of follow-up questions have come. I think they are relevant. Anu, for you, can the results of yellow 3 be extrapolated to inclisiran?
Inclisiran and PCSK9 almost similar, though they have a different mechanism of action, or similar, but in a different way. You're not sure, can it be extrapolated? Can't hear?
Yes.
It cannot be. Can it be extrapolated? Difficult to say, but could be. But definitely other drugs that need to be studied. One of them, which has a different pathway, is benzoic acid.
Samin, last question for you from Nikhil Jha. Are you able to get some sense, paclitaxel, DCB versus sirolimus?
Yeah. So I think that there are 3 trials now. All are identical. There is slightly lower late loss with the sirolimus compared to paclitaxel. Of course, paclitaxel has been much more studied. But I would say that the trials are coming. But definitely there are 3 trials showing the exactly identical clinical outcome. No difference in device thrombosis and similar acute luminal gain, but slightly lower late loss, which we knew in the sirolimus compared to paclitaxel. But clinical outcomes were identical in few of the trials and registries now.
Excellent, Samin. This has been an outstanding year. I want to thank and name some of the people who were involved, not only today, but I noticed they were very significantly involved with our webcast over the years. Dr. Mahmood El Rais, Nikhil Jha, Shantanu Deshpande, Mayank Yadav, Again, there is I don't understand. I don't know who the person here is. They have cited trying to remain anonymous, which we respect. Will's boys, Shoaib Zia, welcome from Pakistan, and Dr. Tulsi Das, thank you all for enlightening us today. We've had a wonderful year. Congratulations, Samin and Anu. Anu, so many additional over the year have been many recommendations thanking you for your exceptional demonstration. A great year to all of you ahead. Merry Christmas and a Happy New Year. We'll see you. Not done yet. Yes, you're correct. December 27th would be the last one. And
27th?
Yeah, 17th,
not
December 17th.
yeah.
December 17th will be our last session, and we'll
Can
see
we,
you.
January.
can we see the
January
slide or
21st.
no?
Yes, we
December
see
the-
that. Beautiful. Healthy mitochondria, healthy body. This is a
Nice
wonderful theme.
Yeah, that's a wonderful theme. So you see that, like you were asking, how can we improve mitochondria? So
January
mitochondria
21st.
can be improved just with simple change, which is exercise. And you remember I was talking to you about non-pharmacological. Many of these athletes do take this non-pharmacological stuff so that they improve the mitochondria as well, and they test for it. They get tested that they're not taking any kind of drug, especially to improve the mitochondria. The biggest thing is avoid junk food, because junk food has been shown to decrease the mitochondrial function. And I think without a lot of evidence, we already see even in the guidelines, physical activity, aerobic. Okay, I just gave a my interview to New York Times on difference between aerobic and anaerobic exercise. So essentially, combined exercise has to be done for this is 150 to 300 minutes per week. That is the European guidelines, American guidelines up to 150 minutes per week. This is a simple one to improve your mitochondria, and we all hope we improve our mitochondria, so we are not on the table getting this kind of imaging PCI.
On this positive note, we end our transmission today. We'll see you on December 17th. I'm sorry. Completely right, Samin. January 21st is the next date, and thank you all for joining us.